A scratch on the eye is painful, and if you see patients in the clinic, urgent care, ED, even the inpatient side in the hospital, there's a good chance that you're going to be the first point of contact for a patient with a corneal abrasion, even if you're not an eye doctor. I'm Dr. Lana Jasper Trotter, board certified ophthalmologist, and in this video we're going to be talking about how to manage a corneal abrasion, when to be concerned, and when to call ophthalmology, even in the middle of the night. A corneal abrasion is a scratch on the eye involving the interiormost layer of the cornea. So this is an epithelial injury, aka an epidefect. You have intact epithelium, and then there's any insult that leads to epithelial loss or disruption. That can lead to an abrasion. So let's talk about symptoms. Number one, bold, underlying pain. Pain is what's going to bring the patient into the ED in the middle of the night. That's what's going to lead to the urgent add-on in your clinic. Pain is often described as a sharp pain that draws a lot of attention, so the patient is really uncomfortable. It can also be worse with blinking. Well, why is that? If this is the eye, and let's say the abrasion is here, so this is a sore spot, every time that you blink, that's rubbing against the sore spot, and that hurts. Oftentimes patients are going to want to keep their eye closed, and that can make it difficult for the exam. Why is there so much pain? Well, the cornea is the most densely innervated tissue in the body, and it's been reported that the cornea is 300 to 600 times more sensitive than the skin. Symptoms include clear discharge, so tearing. The eye can be weeping, blurry vision, photophobia, headache, and foreign body sensation. The symptoms are generally at its worst the first 24 to 48 hours after the insult, and that's generally when you're going to be seeing the patient. The good thing is that if it's an otherwise healthy eye, there's nothing else going on, the eye generally heals pretty quickly. A common question I'm asked is how to manage a corneal abrasion. So let's break this down. When in doubt, anytime you're seeing an eye patient, preservative-free artificial tear eye drops 4 times a day. You're not going to go wrong with that. So with a corneal abrasion, the eye is irritated. The minimum preservative-free artificial tear eye drops, QID plus. So I'm literally saying QID plus because 4 times a day is just the minimum. You can scale up to every hour during the day if the patient is very symptomatic, if it's a large corneal abrasion. So it gives you some wiggle room so you can scale accordingly. I'll leave a link down below with some artificial tears that I recommend, so be sure to check them out. The benefit of preservative-free artificial tear eye drops, there's no limit for the frequency. So you could tell a patient to use them even every 5 minutes if that's soothing for them. And here's a trick. Have the patient put the artificial tears in the refrigerator. It'll cool them so it'll feel really nice on an irritated eye. The second stage of management is using a topical antibiotic to prevent an infection. So a corneal abrasion is not an infection, but it is an infection risk. So the options, an eye drop, ointment, or a combination of the two. For an antibiotic eye drop, some examples include a fluoroquinolone like ofloxacin or Vigamox. You could also consider using Polytrim. These eye drops are used 4 times a day. If you choose to go the ointment route, a go-to that I like to use is erythromycin, and I like the frequency QID because it provides a lot of lubrication, which can be pretty helpful if the patient is really uncomfortable. Anytime I use an ointment, I tell a patient it's going to blur your vision like crazy for hours, and I'll even add on the prescription, will blur vision in all caps. The time for these prescriptions are about 5 to 7 days, depending on the patient case, size of the abrasion, etc. If you're seeing a patient that has a really small, like real tiny itty bitty corneal abrasion, you could consider doing lubrication only. So frequent preservative-free artificial tear eye drops, artificial tear ointment, and holding off on an antibiotic prescription. Now, again, that's if it's really, really tiny, so really small. The patient is not a contact lens wearer. There's no other risk factors, and I have strict return precautions. So something to consider. When deciding between using an eye drop or an ointment, what you can do is let the severity of the symptoms guide you. So let's say you have a mild to moderate presentation. You can have the patient use eye drops throughout the day and then an ointment at bedtime. And you can tell them for the ointment, you can use more throughout the day if you'd like. So that's where the 1 to 4 times a day comes in. And the ointment could be over-the-counter artificial tear ointment. Symptoms are severe and the patient is really uncomfortable. Go with the ointment QID. If the patient is also a contact lens wearer, you're going to want to add anti-pseudomonal coverage, Vigamox eye drop QID. Other times to have Vigamox on your radar is if the trauma was due to a dirty injury, so like a fingernail injury or injury due to vegetable matter. If it's time for both the eye drop and the ointment to go in, have the patient use the eye drop first, wait a few minutes, and then put in the ointment. But something to keep in mind is what people do for their work. So it may not be ideal if the patient's vision is blurry for hours from the ointment and say, hey, just use this ointment. You could adjust that and have the patient use an eye drop during the day and then an ointment. What I often say is 1 to 4 times a day. So I tell a patient you can use the ointment at bedtime and then you can scale up throughout the day, use it up to 4 times a day. Using a frequent warm compress to the closed affected eye 3 to 4 times a day, 10 minutes at a time can be very soothing for the patient. And then for pain management, the artificial tears, so frequent lubrication, ointment, warm compresses can be helpful, but also over-the-counter oral Tylenol or an NSAID, as long as there's not a contraindication, the patients can use as needed. If a patient has light sensitivity, you can consider using a cycloplegic dilating eye drop. So those eye drops have a red top. An example is cyclopentolate 1%. Now, if you're not comfortable using a dilating eye drop, then this would be a good time to get an opinion from ophthalmology or have the patient follow up with an eye doctor. So when should you be concerned? When there's significant visual acuity decline. You've checked the vision with glasses or pinhole if you have either of them, and the vision is poor. LP or NLP visual acuity, that's not typical with a corneal abrasion. A proptotic or sunken-in eye, elevated intraocular pressure, a motility deficit, seeing a whitish, yellowish spot on the cornea that could be concerning for a possible ulcer, a hyphema. Now, can you get a hyphema and a corneal abrasion in the setting of trauma? Absolutely. But what a hyphema can tell you, especially if it's a big hyphema that's obscuring parts of the iris, is that the eye and possibly the orbit just sustained a good amount of trauma. Also, if there's a pupil abnormality, so if it's abnormally shaped, it's not reacting well, if there's an RAPD, any concern for a ruptured globe. So a ruptured globe is one of the handful of true ophthalmology emergencies. So here are some clues. Penetrating foreign body, a positive Seidel test, an irregularly shaped pupil, so the classic tear-shaped pupil if the iris is being sucked out, so prolapsed iris. The pupil is not always tear-shaped, though, in a ruptured globe. Sometimes it could actually be nice and round. If you have significant chemosis with a subconcheme, so imagine seeing 360 chemosis that's bellowing forward in the setting of trauma. That's the clue that the eye sustained a big force. If you have a shallow anterior chamber, if imaging is obtained and it comments concern for a foreign body, whether it's in the eye or orbit, that's concerning. Also, if it comments concern for a possible ruptured globe, whether it's new or old, you never know. If you're in the outpatient setting, and let's say you diagnose a patient with a corneal abrasion, you're seeing them back a few days later, and they're not getting better or they're getting worse, that would definitely send to an eye doctor. So that brings us to when to call ophthalmology. With the list that we just went through, really good examples. A couple of things to add to that: if there's an eyelid laceration, especially if it's involving the canalicular system or tear duct, or it's suspicious enough that it might be. And if you're seeing an eye patient, you're not really sure what's going on, you've done the exam and any workup, and there's something about the presentation that's concerning. So stick around for some bonus content. Let's go through a differential diagnosis of a corneal abrasion in under 30 seconds. That's really fast for me. All right. So we have conjunctivitis, dry eye, episcleritis, scleritis, uveitis, infectious keratitis, aka an ulcer, herpes virus, HSV, VCV. So those are just some examples when, keep it in the back of your mind when you're examining a patient that you suspect has a corneal abrasion. Now I'm done.